presentation. Thank you, recording in progress, very helpful. And I just wanted to start by saying that the Women's Health Research Institute would like to acknowledge that we are uninvited guests on the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And is a provincial research institute committed to improving the health outcomes of women, including those across the 2SLGBTQIA+ spectrum. We recognize our responsibility in the collective effort towards establishing culturally safe healthcare systems and services that address health inequities among Indigenous peoples, especially Indigenous women, girls, and Two-Spirit peoples. And we encourage all people involved in research to read both the Truth and Reconciliation Commission of Canada Calls to Action and the In Plain Sight report, and reflect on the ways that we can incorporate the recommendations into our work. And as we gather in spaces together, we encourage you to reflect on your own positionality on these lands and your personal commitments to reconciliation. So with that, I would like to hand over to Dr. Wendy Norman, who will be introducing today's rounds presenter.
Oh, thank you so much, Catherine. And thank you for those important reflections. It always helps me each time I hear them to just take that step back and realize and appreciate all of the things, pieces that we can contribute to understanding where we've come from, how the people around us are experiencing their contextualization and the cultural and formative experiences that have gone into how their health is constructed. So always brings humility. Thank you. I'm absolutely delighted here as the lead for the Contraception and Abortion Research Team, founding it about 10 years ago within the WHRI and through the support of BC Women's Hospital and the WHRI, co-leading it now with Dr. Sarah Monroe. And we are absolutely thrilled that our International Advisory Panel member for CART, Dr. Rebecca French, is able to join us on site here today in the CART WHRI offices and to be able to provide this seminar for us as we go forward today. Dr. Rebecca French is an associate professor in sexual and reproductive health research at the London School of Hygiene and Tropical Medicine in the UK. And right now, a visiting professor in February and March of this year with the UBC Department of Family Practice and specifically with CART. Dr. French is a public health researcher with over 30 years experience in policy-related research, mixed methods, survey design, intervention development, and evaluation of complex interventions, and is actually a leader in her field in analogous sexual health research to that CART is hoping to and trying to undertake in Canada. Dr. French was awarded the honorary fellowship in the Royal College of Obstetrics and Gynecologists in the UK's Faculty of Sexual and Reproductive Health in 2021 for her contributions to advancing research in this area. Her interests include how preferences affect choice in healthcare, specifically around fertility-related decision-making, and how new technologies and models of care could be used to help people to better achieve sexual and reproductive health as they individually define it in their own contexts. Her recent work she'll be telling us about today, but also includes work with leading the Department of Health and Social Care's funded Women's Reproductive Health Survey in the UK, which was designed to monitor trends across the reproductive life course in England. We are delighted to share that Dr. French, as well as being an associate professor at the London School of Hygiene and Tropical Medicine, which is one of or the top public health school in the world, is a co-investigator for one of the research policy units within LSHTM, the Policy Innovation Public Policy Research Unit, and also at the University College London Policy Research Unit, Reproductive Health Policy Research Unit. So with no further ado, I hand us over to hear from Dr. Rebecca French on her reflections and the research that she's been conducting, innovating and leading the way in the UK in sexual and reproductive health. Dr. French.
Thank you, Dr. Norman, and thank you for that lovely introduction. I'm absolutely delighted to be here in Vancouver and as Dr. Norman said, you know, being a sort of independent member of the advisory group for the CARP program, we've got lovely graphics, you know, about all the wonderful work that's going there. So it's been great to meet people in person rather than on Zoom when I've been here, and also other people in the Institute. And you're all giving me lots of inspiration and lots of ideas to take back to the UK. What I want to talk about today is a specific project. I'm just going to share my screen now. So can everyone see the slides?
They look perfect.
Yep, looks great.
Wonderful. So I should talk, I'll be probably talking about for about 40 minutes. It might be slightly faster because I'm going to go, I realized that John Reynolds Wright, who's a colleague from the UK, also gave a talk and which covered abortion law in the UK. So I'm going to really quickly just summarize that. But if anyone didn't attend John's talk, apparently it has been recorded as well. So this afternoon, I'm going to talk about abortion care in Britain and current trends and future possibilities. And this is drawing on evidence from the SACHA study. SACHA stands for Shaping Abortion for Change. And it took us quite a long time, I hate to say, to come up with an acronym. So it's probably not the best. But anyway, SACHA it is now. And we are a huge team. So I co-lead this work with Professor Kay Wellings, and Dr. Wendy Norman's one of our co-investigators, and really helped us in terms of understanding the context in Canada. But we've got all sorts of researchers involved, from social scientists, clinicians, epidemiologists. So it was a big team across lots of different institutions in the UK and internationally. So very briefly, as you would have heard from John, or you can do if you want to look at the recording, is that abortion law in the UK across the different four countries has a very varied history. And Northern Ireland is the only nation to have decriminalised abortion, and that happened in 2019. And we've got acts that still affect the law today. One's the Offences Against the Persons Act, 1871, and that's specifically around referring that it's unlawful to procure a miscarriage or to supply an instrument or poison knowing that is intended to be used to procure a miscarriage. And at this stage, no distinction was made between abortions that were earlier or later in pregnancy. And under this law, you know, this is the highest potential penalty for abortion in anywhere in a European country. And up till 2022, in England and Wales, there have been 67 cases of procuring an illegal abortion. And these may not have been the person seeking the abortion. It could include third parties. But this is gaining quite a lot of media attention due to prosecutions that have gone on, and, you know, with some going to prison. And then we've got the Infant Life Preservation Act. And so this states, this is from 1929, that states it's unlawful to destroy the life of a child capable of being born alive before it has an existence independent of its mother, unless it's for preserving the life of the mother. Sorry, yeah. And at the time of this law, the gestational limit was 28 weeks, but as there was sort of developments in neonatal medicine, this was reduced to 24 weeks. Then we've got the Abortion Act, and I'm very quickly to go through this, that basically 2 doctors still need to certify in good faith that one or more of the conditions listed, which relate to physical or mental health of the mother existing family, or existing children of their family. The abortion must be performed by a registered medical practitioner, and the abortion must be carried out in an NHS hospital or approved premises. So while it's legal to have an abortion, these constraints still, cause some problems, which I'm going to elaborate on in my talk. So we saw big changes over COVID, obviously, and in March 2020, home management of both pills, mifepristone and misoprostol, were allowed over, and this was supported via telemedicine, either via the telephone or over video. And this was because of real concerns that with COVID, that people wouldn't be able to access abortion. And this was made permanent in April 2022. And from August, the 1967 Act was actually amended to reflect this new ruling. So what was the aim of our study? Well, really, it was to provide an evidence base to sort of help shape health services and health systems in response to current changes in abortion provision in Britain. And this was particularly due, from technological advances, but also really in preparation for changes in the legal framework and regulatory framework. So what did we do? Well, actually, we had sort of 4 broad questions that we wanted to answer. So first was how abortion should be regulated in Britain. What are the optimal models of care? Who should provide abortion and where should it be provided? And we had 5 different work packages in the study. And these were sort of conducted separately, but at the end we sort of triangulated all the findings across these different packages. So I'm going to touch on the first work package, which was a review on the literature, and Dr. Wendy Norman was heavily involved in this work. And this the first review was to answer the question, what support could improve home management of medical abortion? And this was a realist review, and this has been published if anyone's interested in looking at that. And the next bit of work we did, which has not been published yet, was a scoping review, was looking at evidence for interventions aimed at increasing preparedness of non-specialist health professionals for a role in abortion provision. And this was predominantly focusing, looking at sort of training, really. The next works package was a country case studies. And our research question here was, what was the experience of countries that have fully or partially decriminalised abortion? And also, what are the transferable lessons for policy and practice in Britain? And we worked with in 3 countries, Australia, Canada, and Sweden. And methods included documentary analysis, routine data analysis. We did interviews with key stakeholders in these countries, and there were 31 interviews conducted, and these included with service providers, policymakers, and those in the voluntary sector. And again, Dr. Norman was very much involved in this work package. Then we did a survey of health professionals, and this was something I particularly led on. And the question here was, what are the views of health professionals on current and future forms of regulation and provision of abortion in Britain? And here we had it was a cross-sectional postal survey of doctors, nurses, and midwives, or pharmacists working in either general practice, maternity services, pharmacies, sexual and reproductive health clinics, and specialist abortion services. And this could have been either in the independent sector or NHS, but most abortion certainly in England and Wales is actually provided by the independent sector. In terms of sampling, it was a clustered random sample of services, and these were identified via postcodes, and all eligible practitioners within that service were eligible to take part. So any doctor, nurse, midwife, or pharmacist working in any of those services. We slightly oversampled the pharmacies just because there were, most likely it was only 1 or 2 pharmacists working in one service compared to general practice, which would have had many more eligible practitioners, and maternity services, because we covered antenatal care, labour ward and postnatal ward. There were a lot of midwives actually, so we just selected midwives who were working within a 24-hour period to be eligible to complete our questionnaire. So we approached 278 sites, and we ended up with at least one participant returning a questionnaire in 147 of these, so 52, nearly 53%. One of the most common reasons people we couldn't get a site involved was, well, the biggest problem, which was my biggest headache, was we needed to get research and development local approval. And sometimes these departments were just too busy. I have a feeling maybe abortion wasn't seen as a priority sometime, and it was they were very slow in getting a response. Some services just said they were too busy. We were doing the survey over the time of COVID, and then also in terms of sexual and reproductive health clinics at the time of MPOX. So often services, just sort of the gatekeeper, said they look, we're too busy. Amongst these sites, we did have at least one participant. We sent out 1,370 questionnaires, and we got 771 returns, so about 56%. And what in the postal providers did have the option to complete online, but we chose postal because evidence shows that actually people are more likely to respond to a postal survey. I think because post is so rare these days, and people get fed up with being asked to complete surveys online, you know, via email. So that was our rationale. We also included a £10 shopping voucher, non-conditional, which actually some health providers wrote back and said they were very grateful to receive that. Some actually returned the voucher with their completed questionnaire, which was sweet. So we had, our response was highest in the sexual and reproductive health clinics. And in terms of by profession, it was highest amongst midwives. And Scotland was the country that had the highest response rate overall. We also did interviews with patients with recent experiences of abortion. And our question here was, what are patients' recent experience of abortion and what are their preferences in relation to how care is delivered? Oops. Sorry, I've jumped, moving around things. Great, just move that there. So in terms of our sampling and recruitment, patients had to be aged 16 and above with a recent experience of abortion. So that was within the last 2 to 3 weeks for reasons other than fetal anomaly. And they were recruited from both NHS and independent sectors. And we purposefully sampled to ensure diversity in terms of characteristics, but also abortion experience. And these were semi-structured interviews conducted over the phone or over video, depending on preference. And we could do interviews in English, Arabic, Welsh, and Polish, which basically reflects the language skills in our team. So 48 women, and they all identified as women, identified aged between 16 to 43 years, with a range of prior experience of abortion and different methods of abortion. And we sort of were able to have diversity in terms of age and people from ethnic minority groups and all those people who had recently migrated to the UK. And the final bit of work was consultation with key stakeholders. And actually, this was something I found so valuable in the end, and I wasn't necessarily expecting it to be so productive, but we had a 2-day residential consultation with key stakeholders in the UK. And our question here was, what approaches to abortion provision are most appropriate and feasible in Britain? And we developed 5 sessions centered around themes that we'd sort of found from our preliminary analysis, which was around providing patient-centered care, the role of telemedicine, whether abortion services should be mainstreamed or stand alone, extending roles, and regulatory frameworks. And this was just a really good opportunity to present our preliminary findings and, did these ring true? What do they mean? How can we make change? And we had 15 stakeholders from different sectors and with very different professional roles. I should also add, we had patient involvement. We had 2 PPI representatives on our advisory group, and we worked closely with them throughout the project. But we also ran 3 sessions online with 10 participants in general. And these were people who'd had abortion, and we really had an abortion, and we wanted to put again our findings to them to say, did they ring true? What's important in terms of policy and what in terms of dissemination? And I don't go on to present findings from this work. It has been published now, but basically our findings really aligned with their experiences and what they felt was important. The only thing that we hadn't picked up on our study that they identified was really important was about sort of abortion, and work, about having time off, problems disclosing, having to have time off from work. So that was something that the PPI group were able to add to the work that we'd done. So some findings. So the questionnaire that we designed included some knowledge, attitudes, and practice questions. And in terms of some of the knowledge, 78% of the health professionals were aware that a doctor's signatures are legally required before an abortion can be performed. Unsurprisingly, you can see it's highest amongst the abortion service providers. But, around half of those working in pharmacy were unaware of this requirement. 91% of the health professionals agreed that the choice to have an abortion should be completely that of the woman. And actually, this proportion lines very well with general population surveys, which the general population, strongly agree that choice should be, the person having the abortion. Find slightly lower agreement with this statement amongst those working in general practice. And also, in terms of gender, we found some differences as well. So some quotes. In the survey, respondents could leave some free text quotes at the end. And basically, there was universal pro-choice in terms of comments left, and none stated a preference for retaining abortion within, how it's provided within the current law. And the participants commented on the need for specific regulatory changes. So the first quote at the top felt that, as nurses are providing much of the abortion care, they should be the ones to sign off the HSA1 form. And this is the form where in terms of the law, you have to state what is the reason, what's the condition that's being met for the abortion. And this doctor who left comments felt that this was just anarchic, and that it should be done by 2 doctors. And there's another quote from a nurse as well about the need to scrap. scrap the current need for 2 medical signatures. And it was also noted in comments that decriminalisation could offer opportunities for expansion of professional roles in abortion as well. So more than a third of the women that we interviewed were unaware about this law that required 2 doctors to authorise an abortion. And these are some of their comments. We should see that the discovery that this was so during the interview was met with surprise and disbelief. And similar to the comments made by health professionals, women tended to consider abortion care should be treated the same way as any other medical care. And as this one says, it was just felt that this is a box ticking exercise. So when we looked at experience in the other countries and our other case study countries, we really learned about the opportunities for progress created by decriminalisation. So in terms of the stakeholders that we'd interviewed in Australia and Canada, they described how decriminalisation removed barriers to services. They created the impetus for the development of health policies and clinical guidelines and improved funding of abortion services. And it also gave greater legitimacy to those providing abortion care. And it meant that decisions could be made on clinical grounds and abortion care could be regulated through the same structures as other healthcare. But some lessons for us. Progress can sometimes be slow. Resources are needed. And that progress is often driven by individual champions. And provision continues to vary by regional factors. And sometimes there was lack of enforcement at a more regional level. And stigma may be attenuated, but not eliminated. And in Sweden, where there are still some legal restrictions around abortion, they were favour in decriminalisation of in principle, but they felt it wasn't essential. And they thought that actually efforts to change the law could unintentionally result in greater restrictions. They did feel the law in Sweden should be modernised. So in fact, the law was comes from before medical abortion was available. But they felt their current legal framework provided an obligation for all hospitals with a women's clinic to provide an abortion service. And this therefore ensured a greater geographical spread of services. And the other thing that's interesting about Sweden is that conscientious objections is just not accepted. So who can provide abortion care? Well, there was support among health professionals surveyed for extending their roles, but this support was higher amongst the nurses and midwives than the doctors and pharmacists that we surveyed. But even amongst the doctors and pharmacists, we had 1 in 5 doctors and over a third of pharmacists that agreed that extending roles in abortion care had the potential to improve job satisfaction. Supporting decision-making, medical abortion and contraceptive care were the areas with training that professionals that weren't currently providing these roles were most interested in taking on. Nearly 2/3 of those working in sexual and reproductive health clinics and pharmacies would be willing to prescribe abortion medication. For those seeking abortion care, actually they felt that the approach was much more important than what profession the person was from. They wanted care that was supportive, non-judgmental, and timely. And the 2 quotes here just illustrate the value people placed on this. They just wanted to see someone who was kind and that normalized the experience. Some that we interviewed weren't sure whether non-abortion specialists could be relied on to have the same non-judgmental attitudes that the specialist abortion providers do. So which setting? I should state up front that there was really high satisfaction amongst those that, you know, who'd had their care provided by specialist services amongst the patients we interviewed. They expressed some support for initiatives that expand roles where people could receive care, for example, from their GP or from a pharmacy or online. The advantages they saw were mainly around convenience and the potential for normalizing abortion. But there were some that weren't convinced about being able to receive timely care from their GP and highlighted that it would be important to still feel supported and being able to ask questions. In terms of the health practitioners, it was staff working in the sexual and reproductive health clinics who were more receptive to the idea of abortion being provided in their survey. And 35% of all non-abortion specialists agreed that abortion care should be standardized practice in their specialty. And this figure was close to 60% amongst the staff working in SRH clinics, but you can see less than 20% amongst those working in GP practices. And those working in general practice were more likely to say that providing abortion care in their service would be burdensome. So we asked them about what would be the hindrances to extending roles. And actually there was quite a lot of similarity across the different services. But the areas that professionals were most commonly reported that would hinder extension was lack of time, not enough staff, and inadequate training. And interestingly, we found stigma-related factors were less commonly reported. So whether that was, we've got disapproval of colleagues or disapproval of patients or from friends and family. So what did we hear from other settings? Well, we learned a lot. So in Canada and Australia, the provision of abortion in primary care settings was considered by stakeholders that we interviewed. You know, this was really important, improving access, particularly for those living in rural areas. And also provision in primary care was also thought to have contributed to reducing stigma and normalizing abortion as a routine procedure. And as it came out in our survey, actually, we also found in the country case studies that there were capacity, resource, and administrative barriers to extending roles. But we had some really good examples of how these could be minimized. So, for example, in Australia, there'd been a big barrier in terms of GPs providing medication abortion was that you know, there was quite onerous training and registration networks. So they were able to address that. And across both countries, you know, setting up provider networks and communities of practice really helped minimizing feelings of isolation. And this quote from a provider in Australia pointed out that, you know, basically there's a lot of groundwork that can be laid down to help mitigate some of these barriers. But, you know, particularly if you're sort of thinking ahead. Other barriers are more structural and dependent on government level priorities. And I think this is something that we all need to, you know, keep in our minds, and also how the way that health systems are set up. In Sweden, abortion is very much midwife-led, and historically, midwives have played a sort of key role in terms of providing reproductive health care across the life course. So they're involved in young people's sexual health clinics, contraception, provision, pregnancy care, and abortion. And in Sweden, this is seen as a really effective way in terms of, you know, providing patient-centered abortion care. How this would work in Britain is really interesting because I think we just have a very different way of providing midwifery care. But I think this is, yeah, definitely some lessons we can learn from. So what do we learn about in terms of the case for expanding abortion options, abortion care? Well, it certainly there's a strong case that it contributes to normalizing abortion care. It provides continuity of care, and increases access to care. So in terms of access and continuity, again, it's just much more patient-centered, that you can have, contraception care from the same place that you have your abortion. And in terms of access, to care, this can be both in terms of the geographical sense, but also, different services might suit different people and their needs. And finally, expanding options is a form of patient-centered care. It empowers people to make choices depending on their different circumstances about what abortion care would look like for them. We did ask about views on telemedicine in the questionnaire, and this was one of the attitudinal questions. So we did have statements that were sort of negatively and positively framed. So we found that less than 1 in 4 healthcare professionals see the use of telemedicine as unacceptable in abortion care. And opposition to telemedicine was highest amongst those working in maternity, but lowest amongst those in abortion services. And in terms of profession, it was highest amongst pharmacists and lowest amongst doctors. But actually, we found opposition was less among those who felt able to support home management, and among those who already provided remote care. And as this quote illustrates, I think people are concerned normally, but actually once they do get involved in telemedicine, they find it absolutely fine and they enjoy it. And patients' views on telemedicine in home medical abortion care. Most of the top areas that came up in the interviews was that telemedicine was convenient, it was private, and it was comfortable, as these quotes show. But there were some that preferred in-person care, whether this was for medication abortion or procedural abortion. Some wanted a hand to hold. Another person here said, they wanted to have a surgical procedure because it was easier and they felt there was less pain. But this final quote, I think here just basically says, there's not one size fits all. Everyone's in different circumstances. Everyone feels different about their pregnancy. So there's that real importance to have flexibility and options for people to choose how they prefer to do it. So just bringing some of the findings together, and in terms of decision-making, deciding what service to access and understanding your options in terms of method abortion. And we found these could be influenced by, multiple factors. So at a service level, it could be number of appointments required, personal circumstances. You could have caring responsibilities, work commitments. Geography plays a part in terms of distance and travel. Relationships. You might want to keep your abortion private from your partner, family, or friends, or actually you might want their sort of active involvement and support, whether that's at home or in a clinical setting. And the extent of preferred involvement, in the process, desire for autonomy versus having a healthcare practitioner managing the procedure. And obviously there's going to be past abortion experiences. And some of those that we interviewed, had a medication abortion before, and this time had a procedural one, and vice versa. So I think this highlighted the importance of patient-centered decision support aids, in terms of helping people identify preferences and what's important to them. And it's been great discussing the work that Sarah Monroe's done and colleagues in terms of a support aid to help people with what method they would like, depending on their preferences for abortion. In terms of the procedure itself, medication abortion and surgical abortion, what we found was there was often a mismatch between expectations and actual experience around pain, bleeding, and products of conception. And those that we interviewed really want to know what was normal, when should they, when isn't it not normal and they should be seeking help. And even though there were 24/7, numbers they could call, some of the patients just didn't want to bother services so sometimes I think they managed these and it was maybe worse than they had expected for some. And support during the abortion varied as well, from those that wanted to just be by themselves, to those that had some support, to some others that would have liked more support. So in terms of interventions here along the patient journey, what we're thinking, could come out of this is videos and storytelling to provide a range of patient experiences, from those that, pain was quite minor to those that felt it was just absolutely dreadful. So I think it's important, to have, a range of, different experiences. Peer support platforms could be very useful again. And I think we need to think about more, what sort of support could be provided for home medication abortion, maybe particularly for those who are by themselves who would like some more support. So here it's, what potentially is the role of doulas. And support after abortion, contraception. Some of those that we interviewed did say that it was sometimes difficult to make appointments, particularly for LARCs. For those who had procedural abortions, there often is the option to have a LARC fitted immediately post-abortion. And the other thing that came up was digital follow-up to check on the abortion completed, and then also to provide ongoing advice about contraception and emotional support if needed. Some people don't need it, but some people really valued that. So while these are some suggestions that we need to sort of look at to see how we can improve the patient journey, at a systems level, we still need integrated commissioning. We still have inadequate resources. So the tariff payments that providers receive for providing abortion often don't cover things like contraception as well. And we do need to look at further undergraduate and postgraduate training for professional staff. So in conclusion, we felt that our currently regulatory framework for abortion service actually limits our potential to provide evidence-based service innovations that are likely to benefit patients. Patients should not have to give any justification for the reasons for wanting an abortion. Healthcare professionals other than doctors should be permitted to consent for abortions for patients that they're caring for. Abortion provision could be beneficially integrated into adequately resourced community and sexual and reproductive health services. And then we do need to explore future opportunities for provision in other settings. Trained nurses and midwives should be allowed to prescribe abortion medication and perform vacuum aspiration. And midwives can actually already do vacuum aspiration for fetal anomalies, and nurses working in early pregnancy units actually perform vacuum aspiration for incomplete miscarriages. So, in terms of the skills, we have people who can already do vacuum aspirations, and does it really matter, it shouldn't really matter what the reason that they're having the vacuum aspiration is. We need to look at both undergraduate and continued professional education. Much of the education in the UK around abortion is focused on ethics, but rather than, what an abortion is and how it's managed. And we do have real concerns about professionals losing skills in procedural abortion in the UK, which I'm sure John Reynolds-Wright might have spoken about in his talk. Patients really value choice. So in terms of commissioning, we need to ensure, that the appropriate services are funded, and health professionals should be providing information to facilitate choice. And again, that comes to education. So even if people aren't on a day-to-day basis providing abortion care, doctors, nurses, pharmacists are going to be coming in contact with people wanting abortion. So, I think we do need to ensure that sufficient knowledge and education provided within both, as I said, undergraduate and postgraduate education. Intervention should be developed and evaluated across the patient journey. And this is particularly to support decision-making, procedural management, and aftercare. And we need greater visibility of abortion in strategies relating to women's health and sexual and reproductive health care with corresponding action plans. So in England, we've got a women's health strategy that came out in 2022. Abortion is mentioned, but literally it's a word, there's nothing more than mentioned as something that might be experienced by women. So I think, we do need much more visibility at the policy level. So I just want to note, this study was funded by the National Institute of Health and of Health Research, and the views that I've expressed are those of our team, not necessarily those of the funders or the Department of Health and Social Care. And we're busy still, our main report hasn't come up yet. It's we submitted it in September, but it's still being reviewed. But we are getting papers out there, and so we'll be updating our website, as we get the papers out. So, any questions? Stop sharing.
You are still sharing the screen.
Yeah, I'm just trying to work out. I've got the share, but not unshare. Stop sharing. I've got it. Yeah, so please, put your hand up, or I'll look at the, I can look at chat as well.
Thank you, Rebecca. That was amazing presentation and great to meet with you one-on-one. I'm wondering, what are the key, as you're kind of doing your whirlwind tour of these different incredible sites like CART, and you're on your way to Australia, what are the key sort of learnings that you're hoping to take back to the UK into your own program?
Laurie, brilliant question. I'm learning so much. So far in terms of CART, I mentioned really interested in looking at decision support tools, and it's great, all the work that's gone on, as I said, with Dr. Sarah Monroe and colleagues in that work. And so we're having discussions about them in terms of how can we transfer that to the UK context. I think there's so many other things I've learned. What's been really interesting about CART is looking at these very different projects across different specialist areas, from pharmacists, nurses, midwives, and really embedding themselves within the structures in Canada, but also how it's a overarching program. So it's bringing up, and I think that's how we need to think in terms of how providing abortion care. So that's been really interesting for me to take back. And in terms of, you know, how can we link in better with people providing the care, with policymakers, and how, so that's been really interesting. And then there's some other areas really keen to learn from the work of CART in terms of provision in pharmacies. I mean, we can't do that at the minute in the UK, but that's something definitely for the future. And there have been changes in terms of prescribing in pharmacies with oral contraceptives recently. So there is opportunities there. The other area I'm really interested that I've learned from CART is role of social workers, particularly amongst those who may not be accessing care, and, you know, what sort of and social workers, you know, may have very good relationships and long established relationships with sometimes very vulnerable people. So, you know, how can they help facilitate access to reproductive health more broadly, but including access to abortion care? So basically, I'm taking away a lot, but it's really interesting seeing the, as I say, the individual programs, projects, but how the program works together as well. Wendy.
Well, I was wondering, Rebecca, you know, I can see from the many people who've joined this webinar that many are conducting research on their own. And it was wonderful to hear your description of the project and how many complex pieces you brought together into this one project. Do you have things that you've learned about that process, about undertaking such a massive project across 6 countries, across patients, providers, system stakeholders, and decision makers, and what you learned about bringing those pieces together, or actually undertaking such an ambitious project with such a short timeline?
Yeah, I think the different work packages were really complementary. And it helped us understand the sort of big picture of terms of what's going on. So, you know, if we just focused on patients, or if we just focused on providers, it wouldn't really help us understand, you know, what is the type of service, you know, that we should be aiming to provide. One of the lessons I learned, I never want to do another survey in the NHS. I think, Wendy, remember me at the photocopier trying to get all the approvals and questionnaires out, and it was a nightmare in terms of, and actually that's something I feel quite strongly about. I think there's so many barriers to us doing research that actually I find it unethical, you know, but that's anyway, that's something I'm going to write about at some stage. But yeah, I think I'm sure other people in the room, what I loved about working with such a multidisciplinary team, and in terms of who our research participants were, was just, it's that continual learning. And, you know, you may have sort of assumptions when you start some research, but by having such breadth, you know, you're constantly learning, and it's challenged you in terms of your thinking. And hopefully at the end of such a study, you know, you're getting something that you can be applicable to practice and is applicable to policy. And I hope in our case is providing evidence to change our regulatory framework. So yeah, that's my lesson to learn. It's great working with lots of different disciplines and lots of different people. And I think we were lucky. We had a really good team. That's another bit of advice I'd give is, yeah, choose who you work with. You know, you want good teams are fun and effective ways of working. Any other
Questions at all
questions?
from any of our research and institute members?
Well, I left my email. If anyone has, I'm very happy to be contacted. I'll be still working very closely with Wendy over the next few years, I hope, and I hope others as well.
Well, let me then just say a huge thank you from CART for coming and sharing your experiences, the incredible research that you've led over this last couple of years, and your reflections on the conduct of that kind of a complex project with the members of our institute. I think it's been just absolutely wonderful to learn from your expertise, and appreciate your coming to share with us.
Well, thank you very much all for inviting me.
Thank you very
Dr.
much.
French. Thank you.
Bye.